So from the regenerative side, I'm going to say this is just the neck portion of everything. It's not all of the other parts of the body. After I created the first regenerative group around the country in 2011 to 15, I had about 60 PowerPoint presentations that I would do just for teaching physicians how to do regenerative therapies for every part of the body. And that's about double now. There's a ton and a half to teach on how to heal tissue. And the neck is probably my most significant subspecialty. There's about 6 things that I do in the neck that nobody else in the country does. Because you have to have the technology, you have to have the understanding of anatomy, you have to have the visualization and guidance, you have to have slightly larger than average cojones. I had the upper cervical chiropractors in here a couple of weeks ago, showing them what I was doing with the upper cervical spine, C0 to C2. We're talking C1, C2 nerve roots, we're talking the vertebral artery, not being that far from the spinal cord and a lot of the things that I do, and they're all looking at me going, you are freaking crazy. Well, I've been developing this for 12 years. Being very careful is next to godliness when it comes to the upper cervical spine. But Dennis and I have created an amazing amount of protocols together. And this is kind of where I'm finally starting to come out of my little dusty room in the basement, where I've been redeveloping and recreating all of the things that I knew in the first 8 years for the last 5 years. And bring these things out for everybody to know and understand and be able to teach them. So upper cervical instability, herniations, these are the really difficult cases. Borrelia syndrome is a constellation of symptoms that include headache, instability, loss of normal position sense, changes in mood, changes in, hearing, sight, and I think that's 5 or the 6. That was described by 2 different guys. One was French and one was from the Orient. And then we make Hansen syndrome out of that by adding vagal and sympathetic dysfunction to it as well.
Right?
Yes.
That was described, how long ago was that described?
40 plus, about 40 years ago.
Okay. That's about right. Has anybody taken a group of those people and ruled out infection?
I have never seen that.
Right, never tested.
So it's typically associated with upper cervical instability, so C0 to C2 instability. How many of those are infective also? Not sure. I don't even know how they actually established upper cervical instability in individuals. I didn't look into it that deeply because I had a patient from Texas that had treated her hips and pelvis previously when I was in Colorado. She was in Iowa from Texas, called me up and said, I have to see you, my neck is bad and I have this condition. And I'd never heard of it before. I've been doing neck for 7 or 8 years by that time.
But it's not a structural thing, it's a neuromuscular thing.
It's a structural thing that leads to neuromuscular
Or just a neuromuscular disorder, the hypertonia lead to the structural way. That's where I'm going. I mean, at some point in time, what's the upstream cause of this?
I would say mostly it's static stabilization loss, so ligament capsule joint, then it's usually traumatic injury and or Ehlers-Danlos syndrome, like a collagen.
But that's now known to be, that is largely now being recognized as something that's acquired. So what I'm getting at, immunologic toxicity infection, those 3 things bound at the hip cause most of these things. POTS is 90% of the time is lying.
So we're,
yeah,
it's like, yeah, that's why we
part of the work.
That's why we need each other.
Yeah.
Yep. And anyway, she's in Iowa. She called me up. She said, "You got to treat me." And I was like, "What the heck is Borrelia syndrome?" I've been like 8 or 9 years into this, and I'd never heard it before. So she was my first Borrelia syndrome patient. Funny as heck, actually. Nina. It's not Nina. It's Nina. Very funny lady. Okay, this is a patient. I had her permission to give this information out. She had 3 injuries to her neck over about a 5-year period of time, like 30 to 35 years earlier. Headaches, changes in balance, changes in mood, changes in vision, changes in hearing for that period of time. A very significant problem. Let's see, so she had all those things. Signed her up for doing all of those things together, trying to do a very unified approach to healing all together at once. She saw Shannon, she saw Dennis, she started doing some, she saw Carrie, started doing some, she already had a functional provider, but then, started doing some energy healing, energetic injections all at the same time. These are my initial injections on her. After doing digital motion x-ray examination and had taken all the information from all the other patients, from all the other providers. 55 structures injected, 2.5 hours in the procedure room. Just doing the atlanto-occipital membrane, the C0, C1, C1, C2 segments, that's about 45 minutes to be up in the upper cervical spine, very carefully getting the needle up to the capsule of the C0, C1 joint. A third of your brain's blood supply on that side goes right across that joint usually. And that's traditionally been done by interventional pain docs who are doing it semi-blindly under fluoroscopy, so they don't see any soft tissue. They can't see any blood vessels. They're doing this, hoping they don't hit the vertebral artery. Geez, that's scary as heck. Because even seeing it under ultrasound, it's scary. Every time. I have to have this condition in my repertoire because it keeps me super honest and never gets boring. Always challenges me. 2/3 of the way down, stellate ganglion block. This is a super interesting thing in and of itself. That single injection, I now have a pipeline from the military and a pipeline from St. Paul Fire Department, Fire Department, to do these on them for free. These are, the stellate ganglion block was started by a guy named Sean Mulvaney. He's one of my buddies, one of the other original guys doing stem cells around the country, innovator in and of himself. Head doc for the Navy SEALs, started doing stellate ganglion blocks on guys that had PTSD, and found 80 to 90% of them could go back into their combat roles with no symptoms. And I've used that very prolifically now in my patient populations, now suggesting that they actually do that and work with the energy healer whom you're gonna meet very soon, before you ever do any regenerative work, because of starting to scoop out all that really difficult, scarred emotional baggage that they have. Not an easy injection to do. I've got to go past 4 or 5 different vessels and 4 or 5 different nerves, and when I get there, it's still, you still got to be careful what you're doing. I actually dissect, not kidding you, I dissect the stellate ganglion off of the carotid artery. When I say dissect, I'm using fluid to remove it and de-adhesize it. Is that a word? From the carotid artery, because there's something in the back of my brain that says that the carotid artery yanking this thing around all the time is not a good thing. But 80 to 90% of people, within 10 minutes of the injection, boom, they're like, wow, I feel really good. I feel really relaxed. I feel really happy. Nobody has any idea how it connects to the brain. But that then combined with doing energy work and some sort of psychological work with a established kind of practitioner, huge boon for the emotional side of the spectrum. Why did I do all this? Because of the digital motion x-ray, my examination, ultrasound, failure of other approaches. Somebody else mentioned that. I love all that information. That's, what did they do previously? I don't have to reinvent the wheel on every single person. This idea of a regional and interregional approach on people was something that was, at least as far as I know, unique to me in the regenerative medicine world. That, if somebody's got a problem with a joint, a disc, something like that, you're treating the last thing that was problematic, if that's what you treat. All the things that led to that being problematic, if you're not treating that, eventually that thing is going to fail again. So you can't just pull that last domino out on the whole string of them and say you're good. And then interregional, say for the neck, Dennis and I have figured out temporomandibular joints, sternoclavicular joints, acromioclavicular joints, and the first rib attachments. Extremely important to what's going on in the neck. So all the stuff that happens in that region, plus the things that are strongly affecting them, is the way that we approach this for a regular regenerative case. But for fluoroquinolone toxicity, super important to do that complete. So she thought I walked on water for about 6 weeks, because for the first time in the last 35 years of life, she didn't have any headaches. And started right after injections. I can't exactly explain that, other than,
Cause and effect?
What's that?
Cause and effect?
Well, I'm not sure exactly how that happened though. But I've seen it happen quite a lot of times with stem cell therapies early on. The chemistry changes that are happening in the area, or neurologic changes that are happening in the area. My thought pattern is people's chemistry is so caustic that acute inflammation, acute healing reaction happening is far better than that caustic chemistry or neurology or those two working off of each other. And then she continued doing all of those things. Very dedicated patient. Repeated, headaches came back. We ended up repeating her procedure after about 8 or 9 weeks. She's about 80% improved by 4 weeks. Something that I've learned, it took me like 12 years to learn this, true healing of soft tissue and nerves is a 6 to 12 month process for new tissue to be formed and new neurologic function to be established. The only way I got there was having these very, very complex procedures that I do unmasked what true healing actually is. Because people's decreased symptoms made you think that it was happening quicker than that, but true tissue formation, neurologic rearrangement and growth, 6 to 12 months. That's what I tell all of my patients, but especially fluoroquinolone toxicity patients, because there are a lot of reasons for them to have problems. Began her extensive dietary intervention because Carrie came into the picture. Really significant improvement in mood and energy after working with Carrie.
It was 60% after 10 days, just saying.
Headaches down to 1 to 2 per week. Focused symptoms became cervical-occipital junction. Then I did her C0, C2 again. And then we worked on dissecting her brachial plexus, this whole huge bunch of nerves, all of her musculature. And I ended up creating like 2 or 3 different kinds of procedure paradigms just because of this patient and her really extensive history and the fact that she didn't stop. You guys can look over that quick. Just continued symptoms. Oh, why is this difficult to be the gold standard of care? Really difficult to get this degree of technical skills. Equipment, lab, very expensive. You guys can come see the clinic downstairs if you want to. I don't know if you do this or not, but my clinic is 2 floors down. Having the skilled group, the village, the rest of the village around that person. Difficult to find individuals like this. I will tell you all, I'm extremely blessed to have these people working with me. It's amazing. And as I said, everybody who comes in from out of town will look at me and say, how did you get all of these people together? I don't know. We were all lonely and we found each other. It's a country song. No insurance. Administrators, I don't like these people. The ones that come and tell you from a financial standpoint what you can and can't do. Lack of patience and persistence. This patient was so persistent. She ended up doing 3 digital motion x-rays. She was just dedicated to a T, and it's like she was almost drugged. Like she got a little better and she wanted more and wanted more and wanted more and wanted more and wanted more. And yeah, it costs some money. Here's what it looks like to do a C0, C1 injection on somebody. So I'm going back and forth between 2 forms of visualization. That's the spinous process of C1. Then I'm going to take a picture with, this is fluoroscopy. You can't see the picture very well, unfortunately. you'll start to see my needle working down through the tissue here. It's gonna get over that C1 hump. And if somebody wants to look at a neck downstairs, I can show you the vertebral artery and the C1 nerve root and how intimate these tissues are with what I'm doing. But I'm gonna put that down for a second, and now I'm gonna watch under fluoroscopy. And actually, I do these a little more intimately back and forth now, because this was about a year and a half ago that I took this video. Where I'm looking under fluoro and seeing, where is this, what's going on? Where is this, what's going on? Where is this, what's going on? These are scary structures to be working around. This was an amazing, I just threw this in there because this isn't actually this patient, but that's the C0, C1 joint right there. Here's all of the ligaments that I injected after pulling out of that joint. That's actually the joint right there, that dark line, that's the contrast inside the joint. And you have to use a little bit of contrast with these deep intrinsic spinal injections. But these are all the ligaments associated with that joint right there. So if you just go in and inject that joint and then pull your needle out, you missed everything that holds that joint together. So doing these injections and actually working then the ligaments, the capsules, doing them slowly, moving that needle around very carefully, trying not to puncture the vertebral artery. Not a small thing to do. This is why I call it microsurgical techniques. These are not simple injections anymore. This was her C1, this is actually a different patient, but that's C1-2 joint right here. That's the contrast inside the joint. That's contrast going up. This is the
Dens.
the dens of the axis, and then the atlases on either side. That's traveling right next to the spinal cord. There's a tear in the joint right there. That's allowing that contrast material to go up right around the spinal cord. It's very difficult territory to be working around. And then here's these masses of ligaments again. Look at all these huge ligaments going through here. There's so many places that I know that traditional pain medicine trained are injecting inside of discs, sometimes inside of facet joints, but they're missing all of these structures that actually hold everything together. And look at how pronounced these ligaments become as I'm going from joint to joint and ligaments in between them. You got a whole mass of tissue all holding that together. And that's just one side. You're doing both sides and in the middle besides that to actually get these to heal and coherently back together. Here's what it looks like when we're doing the central ligaments. Spinal cord runs about right to my right here, right there. So I'm getting pretty intimately deep down there. That's what those ligaments look like. And these are the ligaments that are in between these spinous processes. They go all the way out to over here. This is the ligamentum flavum, which is right behind the spinal cord. So getting these needles very, very deep in intrinsic locations, very important for it to be able to heal all those collagenous tissues. Oh, and yeah, look at all these. These are all the different things that we're doing just for the neck, the neck region. So I love her before and afters and being able to show this. So on side bending, she never had a lot of tremendous problems. And she changed just a little bit in her position, not a lot. That side bending just a little better. If you can see, just a little overhang over here, a little less overhang, nearly perfectly squared up here. The amount of force that it takes for ligaments to become unstable, just 1 millimeter. How many newton meters would you guess, Dennis?
270.
It's a huge amount of stress for there to be just 1 millimeter of instability. So to get that back at age 60, after doing regenerative injections twice on there, pretty phenomenal. These ones are where the money shots are. Lateral mess of C1 over C2. See about the amount of overlap here. See the amount of squareness to that part of the facet joint. A little better, a little more rounded, a little bit less hangover. Look look at, it doesn't project terribly well, not happy with that. You can come look at it later, you can see it quite a bit better on here, but quite a bit less overhang on that one. And then this one is even more significant, I think. If you're looking here, to here, to here, there's almost no overlap anymore, and we're back to a rounded state. That's bone spurs resorbing and becoming native bone again. That's, according to orthopedic surgeons, that's impossible. That does not happen. Here's what I was talking about a little bit earlier. I just finally put this graph together a couple of months ago. But when somebody comes in with symptoms, they're going to get worse over a period of time, 1 to 4 weeks. And then they're going to go like this over 6 to 12 months. The more symptomatic time frames are when there's more stress, they've slept bad, they had too much activity, they perhaps got refluxed by some sort of mechanism, their hormones are low, they went to the fair and ate a bunch of crappy food, they got in a fight with their spouse, that kind of stuff. And these down ones are the opposite of those things. Everything is physiologically and emotionally going well. And where this point is, I have to think of something to call that, because that's when I see people consistently saying I'm definitely better than what I was when I started. And that's usually like in the 3 to 8 month time frame.
It's called the intersection of hope.
It might become that. And I see that pretty consistently with people, and I saw it getting a little further back as I got more complete doing these regional and interregional approaches, working really completely with physical therapy and chiropractic, and physiologic work on people. Now my goal is to actually take these guys and get them down here a bit more. I'll start using low dose naltrexone and in non-floxes, low dose Celebrex. Try to reduce those symptoms a little bit during the initial after procedure period. This is what it looks like downstairs. You guys can come and see it if you'd like to. Most important thing in there, that's fluoroscopy and ultrasound. There's an arthroscope over next door, but most important thing is that really cool speaker up in the corner. If you put music on that the patient really enjoys, they feel a lot less pain. It's way more comfortable for them. It's a funny phenomenon. So that's just one example of just that part of intervention from a regenerative standpoint.